Well, good morning, everybody. Thanks for joining us. This is Journal Club for the UTMB Residency in Aerospace Medicine, and kicking off our year in January here. We appreciate your attendance, and welcome to the folks who are listening in from off-site. This morning, we're privileged to have Dr. GR Berman join us for a talk this morning. It's flu season, as everyone knows, so it's a very interesting topic that we're going to hear about today. So I want to tell you about Dr. Berman. She's originally from Wisconsin, went to medical school at Loyola in the Chicago area. She did internal medicine residency at Medical University of South Carolina, and has worked as a hospitalist for a number of years. She came to UTMB about 10 years ago and has a special interest in vaccinations, and she's in a good place. UTMB has a special interest in vaccinations as well. Currently, Dr. Berman is the Damon and Carolyn Gowan Professor of General Medicine at UTMB. She's Associate Professor of Internal Medicine, and she happens to be the Medical Director of the Anticoagulation Clinic as well in the Department of Internal Medicine at UTMB. So with that, I'm going to go ahead and let Dr. Berman take over. Thank you very much.
Good morning, everyone. Thanks for being here. I'm so excited to talk to you about vaccines. This is one of the passions of mine. In my topics today, I'm going to review the routine vaccine recommendations for adults. Now, I realize that many of you take care of astronauts, their families, as well as their dependents, but I'm sure some of you also practice in urgent cares and in clinics, so these recommendations are really important to know just for your general population. I'm also going to discuss updates on the most recent Advisory Committee on Immunization Practice recommendations. And this is a group of 15 members who are nominated by the Health and Human Services, and they meet 3 times a year. And their recommendations become valid once approved upon by the CDC director and then published in our weekly CDC morbidity and mortality report. And then finally, I'm briefly going to discuss some travel vaccinations for astronauts as they do their training internationally. So with some general recommendations when it comes to vaccines, it's okay to give a vaccine if someone has a current or recent illness or if they're on antibiotics. This does not affect the efficacy of the vaccine, nor does it increase the risk of an adverse event from a vaccine. Now, some examples of this is if a patient has a mild upper respiratory infection, if they have a diarrheal illness, it is okay to give them a vaccine. And we do this all the time when we're treating patients in the hospital and we discharge them, say for even community-acquired pneumonia. We are sure to give them their influenza vaccine if in season on the way out. Now, the decision to withhold a vaccine in a more moderate to severe illness is not that it's necessarily contraindicated, but we don't want to confuse the treatment of the underlying illness. For example, I was treating a patient in clinic the other day with acute polynephritis, and it was really important for me to monitor for fever as an outpatient. So I withheld the vaccine because I did not want any potential adverse effect of the vaccine complicate what I was treating her with. Now, if someone had a reaction to a vaccine, if they had tenderness, redness, swelling, fever, that's not a contraindication for them to get a vaccine again in the future. Of course, if they had an anaphylactic response to the vaccine, that would. Now, except for the flu vaccine, which must be given annually, as far as immunosuppressive therapy, it's best to withhold vaccines during that time. Now, if you know what's going to happen, say if you're anticipating putting a patient on rituximab, if you're going to start chemotherapy, it's best to give an inactivated vaccine at least 2 weeks prior. And for a live attenuated vaccine, it's best to give at least 4 weeks prior in order for the patient to mount an appropriate immune response. And then once they finish with their immunosuppressive therapy, approximately 3 months after, when they reconstitute their immune system, that's when you can give them their vaccines. And then for pregnant women, you need to avoid live attenuated vaccines just because of the potential harms to the fetus. And for immunocompromised, we also want to avoid live attenuated vaccines. So one of the fun things about giving a lecture at the end of the year and the beginning of the year is you always get to talk about the year in review. And 2017 was very busy as far as vaccines. I'm sure everyone in this room by now has heard about Shingrix, which I'm going to talk about, the new shingles vaccine. There's also been some updates. The CDC has made a recommendation for the MMR. There's been more outbreaks of mumps throughout the country, so they did make the recommendation for a 3rd MMR vaccine for those individuals who are at increased risk during outbreaks. There's been some changes for updated recommendations for influenza. which I'll speak with, again, not using the live attenuated vaccine, again, reinforcing it's okay to give an egg allergy, and some also reinforcements that it's okay to give in pregnancy. For hepatitis B, there has been 2 changes over the last year. One is just some definition about chronic liver disease recommendations, which I'll talk about. And the other is that there's an FDA approval of a 2-dose hepatitis B vaccine. So the ACIP still has to review that, but hopefully in the future that will be something that we can utilize to increase our vaccination rates with the decreased schedule. Hepatitis A and yellow fever, unfortunately, there has been some vaccine shortages. And this has been problematic with hepatitis A because we have been seeing some local outbreaks in the country. Fortunately, this does not affect the pediatric supply, but that is something as far as our adult population that you may have noticed in your clinics you've had difficulty getting. For yellow fever, we're expected to have that vaccine back in production about mid-2018, so that could be troublesome for some people who want to go to travel where yellow fever is required for entrance into the country. And then lastly, for meningococcal and HPV, unfortunately, due to time constraints, I can't talk about those vaccines in detail as I would have liked. If you guys have questions about them, I do have some slides I can talk about. But these are primarily adolescent and young adult vaccines. The updates in 2017 for the meningococcal are recommendations for the HIV population to get their MCV4 vaccine. For the Men B, the update in 2017 is that you can actually use a 2-dose schedule for the Tremenda and for people who are otherwise not at an increased risk for having a hepatitis B, which pretty much just qualifies for our college students. And then the Metamune, that's a polysaccharide meningococcal vaccine that is no longer in production. So for those adults who are older than the age of 55 who are going international travel to the meningitis belt, it's now recommended that they get the conjugate vaccine. And then lastly, for HPV, the one update in 2017 is that for adolescents who receive their first dose before the age of 15, they only need 2 doses of the HPV, not 3. Now, for our community, if we're seeing them as an adult, or if they're immunocompromised, if they got their first dose after the age 15, they would still get their 3-dose series at 0, 2, and 6 months. So here are the evidence-based recommendations for vaccines for adults. There's 13 listed here. This is taken from the CDC. They have it grouped by age recommendations as well as medical condition recommendations. This is an excellent resource. I encourage you, if you have any questions, to go to the CDC website, look at the footnotes, and they will explain in detail when it's appropriate to give which vaccine. Now, unfortunately, vaccines for adults have not hit the press, if you will, as much as the children's vaccines have. Our pediatric colleagues do such a better job of vaccinating our kids, and with adults, we are lacking. So this survey we do every year looking at the uptake of vaccines in our adult population, and you can see it's about 50 to 60% overall at the most. So for our tetanus vaccines, for those older than 65, it's approximately 50%. For those younger age group, it's almost at 60%. Pneumococcal vaccination in our elderly, only at 60%. Now our Healthy People 2020 goals is to get that up to 90%. Our pneumococcal vaccination in a high-risk category, the 19 to 64, is only at 20%. And our goal to get that to, by the year 2020 is to get it at 60%. Now, zoster, we've done better at, I guess, relatively speaking, if you look at our goals, but still that goal was only at 30%. So you can see, as a general, this is something that we can improve upon. And flu is no better. You know, overall, our vaccination rates for influenza for all age groups is 43%. Less than half of our population overall is getting their influenza vaccine. Now, it's better for the elderly population at 65%, but this is something that we can do better at. And I think we can all agree that flu season is here. This is taken, I got it from the CDC yesterday. This is what the map looks like right now. Flu is here, it is rampant, we're seeing it all the time in clinic, we're seeing it in the hospital. And right now, when you look at the peak, on average, the influenza-like illnesses typically is about 2.2% as far as what we're seeing in clinic. And currently, it's almost at 6% per week of our outpatient visits. Now, you can see we haven't even peaked yet, and we're already as high as we've been in the past. The only one flu season that's been worse, you can see all the way to the left, was the 2009 H1N1 pandemic. The flu vaccine, takes about 6 months to manufacture. And the decision to make the flu vaccine component is made at the end of February. And they do worldwide surveillance to see what strains are circulating in order to put in next season's vaccine. They will always have an H1N1 component, an H3N2 component, and either 1 or 2 Bs, depending if you have a trivalent or quadrivalent vaccine. This year, we have a good match for the H1N1 and for the B components. And when you look at the majority of flu cases, it is influenza A. In fact, usually in a flu season, about 25% or less of the cases are influenza B. And this year, we are an H3N2 predominant season. Unfortunately, when we are an H3N2 predominant season, that usually is a more severe influenza season, especially in our older adults. Now, of interest, of our type Bs that we are actually able to subtype, 90% of them are that Yamagata lineage, which is the one that's only found in the quadrivalent, not in the trivalent vaccine. 1/5 of people in the United States get influenza each year. It is the most frequent cause of death from a vaccine-preventable illness. Up to 49,000 total related deaths per year are from influenza. And the highest levels of death are when the H3N2 virus predominant. So pretty much this season, what we're having right now. And 90% of these deaths are among our elderly groups, 65 and older. So risk factors for influenza are very young, less than 5, are very old, 65 and older, and the presence of chronic medical conditions. So hopefully this is going to be really easy to remember because everyone should get the flu shot. Everyone 6 months and older. And this was ever since the 2009 pandemic. In 2010, they updated the guidelines. They said, let's give it to everyone. Now, the highest priority would be good to know in case there is vaccine shortages. And also, if you have those patients who may be a little more resistant getting their vaccine, if you find that they take care of or live in someone in this high-risk priority group, they are more likely to get vaccinated. For example, if I have those otherwise healthy people, maybe in their early 60s, they say, nah, I never get sick, I don't need the vaccine, and they're showing me pictures of their new grandkid, they walk out with their flu shot and their Tdap. So that is really something that I hope that you can encourage with your patients or even friends. Another thing I wanted to point out, pregnancy is a very susceptible group of people that can get sick with influenza. And the ACIP did strongly recommend that they can get any age-appropriate vaccine except for the live attenuated, and they made those recommendations again last year. The timing should also be very easy to remember because it's just recommended to get the vaccine as soon as it becomes available. The optimal time is before we see activity, and you want to do it ideally by October. Now, the one thing we know about influenza is that it's extremely unpredictable. I can tell you this year, we started diagnosing influenza at the end of September, early October. So there's really no good time to get the vaccine because you don't know when you're going to start to see activity. And you do want to continue giving the vaccine throughout the season as long as the influenza viruses are circulating. And there are many different types of vaccines. I can tell you when I was first practicing as a resident, I just thought you had the flu shot and the nasal spray. I didn't really realize that there was many different types to choose from. And I don't really expect you all to know the details in and out of these, just know what you have available in your clinic. But some highlights from these different, the standard vaccine, that's probably what we think about when we say we're giving someone the flu shot. It comes in a trivalent and a quadrivalent. I know at our clinics down on Harborside where I practice, we have the quadrivalent available. There's also the intradermal low dose. That might be ideal for someone who has needle phobia. It uses an ultra short needle. It's like a tuberculin needle, and it goes underneath the skin. So it uses the dendritic cells to help with the immunogenicity of the vaccine. It uses 1/3 of the antigen, and it's in a single dose vial, so it doesn't have any thimerosal if they have an allergy to that. It does have more side effects than the standard dose as far as causing some erythema, pruritus, some redness, but no increase in pain. We have 2 vaccines that are approved for the elderly population, 65 and older. That's the high dose, and that's the MF59 adjuvanted, which was actually FDA approved in 2016. So the high dose has 4 times the amount of antigen, and it's actually been FDA approved in 2009, and they did some subsequent studies looking compared to the standard dose, and it works better in the elderly population. It's 24% more effective in reducing influenza in 65 and older than the standard dose. Now, because it's 4 times as strong, you're also more likely to get injection site reactions, and it is more expensive. However, it is covered by insurance plans. And now the adjuvant, whenever you have an adjuvant to a vaccine, it increases the immunogenicity. And this oil and water emulsion vaccine does just that, and it does it in a dose-sparing way. So you only have 15 micrograms of the hemagglutinin per component. Unfortunately, they have not tested this in the senior population, but when they have tested it with the standard dose, they did find that it was more effective. Now, the problem with all of these vaccines I just mentioned is that they're produced in eggs. And whenever you have a vaccine that's produced in eggs, it actually decreases the efficacy, because the vaccine virus, when it's made in these embryonic eggs, it makes some amino acid changes which make them less effective, but they do that in order to replicate in the egg for which it's being made. And in particular, this affects the H3N2, which is another reason why we always see a decreased efficacy with that strain, which makes the cell culture and the recombinant vaccine very attractive for future use. The cell culture is produced in mammalian cells, and the recombinant, it uses a insect baculovirus recombinant technology. And in fact, when they looked at the recombinant versus the standard dose, they did find it to be more effective than the standard dose. And then lastly, the live attenuated nasal spray. This is something, again, we're not using for the 2nd flu season in a row because of the decreased effectiveness that we've noticed in prior flu seasons. I don't know if you remember previously, this was actually recommended in kids 2 to 8 over the standard dose, but again, we're not using it this season. So the ACIP does want to hit home that it does not matter, except for the live attenuated, which vaccine you use when you're seeing your patient. Egg allergy is another thing that's been stressed again. So the risk of influenza strongly outweighs the risk of an allergic reaction. And these flu vaccines, they don't really contain enough of the egg protein to cause a reaction. So the recommendations for any patient who has an allergic reaction to eggs, they can receive any inactivated vaccine, recombinant vaccine. They previously even said live attenuated, but since we're not using it, I did not include it in the slide. And this includes an egg allergy to hives. And this even includes more severe egg allergy symptoms if they have angioedema, respiratory distress, if they required epinephrine. In fact, the only update from the ACIP is to perhaps use this vaccine in a medical setting and monitor them for 15 minutes instead of getting it at the pharmacy. I think in this situation, for myself, if I knew someone had angioedema with eating eggs, I would probably opt for the recombinant vaccine. But again, any of them are appropriate. So the effectiveness. Vaccination against influenza is the most effective way to prevent infection. Now, the effectiveness of the vaccine is variable, and it depends on the age, the health of the patient, the type of vaccine that you use, as I mentioned, and the match. In general, for younger adults, the efficacy can range from 59% up to 73%. And for older adults, it's really some conflicting data. We don't have a lot of good trials really pointing towards an exact number. But in general, it's anywhere from 43 to 58% efficacious. Another way to think about these vaccines is a term called vaccine preventable disability. Meaning, even though it's only partially effective, it can still prevent many people from coming down with the flu and make it more milder for those who catch it. People who get influenza, if they get influenza and get admitted to the hospital, they walk out with a wheelchair. So if we can prevent them from getting in the hospital, again, that's going to help prevent their disability overall. Another thing to keep in mind is that since this disease is so common, even with some modest effectiveness of the vaccine, you're still getting a large proportion of the population because it is so common. And they've done a modeling study where they find that even in a low vaccine effectiveness, with say 66% coverage, which is what we see in our elderly population, this can avoid 13,000 hospitalizations. And if you increase the effectiveness of 40% with 66% coverage, you can avoid 60,000 hospitalizations. You saw a patient and said, hey, we have a vaccine to help prevent a heart attack. Do you think they're going to want it? You can say, oh, great news, we have it. It's called the flu shot. Found that acute respiratory illness or influenza-like illness increases a heart attack risk by twofold. And if someone has an existing coronary disease, that is increased by fivefold. So what's so interesting is that the influenza vaccine is on par or better than already accepted measures such as statins, such as antihypertensive agents, smoking cessation. So we can prevent people from getting a heart attack just from getting their annual flu shot. In fact, this is recommended as secondary prevention by the American College of Cardiology and the American Heart Association. Has anyone heard this yet? That I think whenever this hit the news, as far as the 10% match, I was talking about 5 times a day why they should still get their vaccine. They're like, oh, why should I bother? It's only 10%, right? Now, where did this come from? So this figure came from the low effectiveness from the 2017 Australia flu season. And what we know is we typically follow the southern hemisphere when it comes to influenza. And their vaccine effectiveness was about 33% overall. And they had a terrible flu season where it was also H3N2 predominant, and they were only 10% match for their H3N2. Now, we are using the same composition of the vaccine for the northern hemisphere as the southern hemisphere. And the good news, even though we are having a bad flu season as far as that's concerned, is that H3N2 that they had in their flu season is not identical to the H3N2 that we are subtyping currently in our flu season. So our vaccine should be as effective as last year, and this is assuming minimal changes of circulating H3N2, which basically says that we are going to be 32% effective against H3N2 and 39% effective overall. Now, again, you don't want to discourage someone getting their influenza shot because even these numbers can sound dismal to the population. But remember, even though if it doesn't have great cover for H3N2, they're still going to get coverage for the other subtypes as well. This is probably another thing that we hear quite often in the clinic. No, I don't want the flu shot. It gave me the flu. So, some talking points to help with that is that this is a killed virus. It cannot cause infection. About less than 1% of people who are vaccinated, they can develop flu-like symptoms, but this is not the flu. Also, protective immunity does not develop until about 1 to 2 weeks after vaccination. So if someone actually got their flu vaccine, perhaps the next day they had laboratory-tested influenza, you can say you were exposed prior to your vaccine. The vaccine did not give you the flu shot. Another thing is people mistake the flu for any illness where they have a cold, a runny nose, even if they have diarrhea, they're like, oh, I have the stomach flu. So you have to educate them that that's not influenza. And finally, no vaccine is 100% effective. So if they had, say, their influenza vaccine in October and then in February they get influenza, and I've had patients try to blame the vaccine, which doesn't make much sense given the time period, but you have to let them know, thank goodness you had your vaccine because you could have been a lot sicker if you didn't get your vaccine. So really my take home with influenza is please do not offer your flu vaccine to the patients. Do you want a colonoscopy? Do you want to start insulin? No one wants to do these things. No one wants a shot. You need to recommend the flu vaccine. So great news, we have our flu shots in today. We can give it to you. Have you had your flu shot yet? No? Well, I strongly recommend that we give it to you today. And if they say no, then ask them why. And then that way you can try to see what their hesitancy is, and maybe you can increase your vaccination rates. So in summary, for influenza, CDC recommends everyone 6 months or older get their vaccine. You want to avoid, again, the live attenuated this season. You can give it with an egg allergy, and you can give any pregnant woman or any FDA-approved age-appropriate flu vaccine except for the live attenuated. Now, I definitely spent the most on influenza, again, because it's here, we're seeing a lot of it, and if we can encourage vaccination rates, I think we'll be doing great. So moving on to Streptococcus pneumoniae, this is another leading cause of infectious disease and serious illness in the United States. This accounts for 4,000 deaths per year. It's the most common bacteria that causes meningitis. It's about 70% of our cases, where there's 3,000 to 6,000 cases per year, and there's a 22% fatality with this bacteria despite appropriate antimicrobial therapy. Bacteremia, which is a common complication of pneumococcal pneumonia, which can happen 25 to 30% of the time, that accounts for more than 12,000 cases, and there's a 20% fatality in our younger population and can be up to 60% in our elderly. For pneumonia, for meningitis, I forgot to add, the fatality can also get up to 80% in the elderly. And for pneumonia, the most common bacteria that causes pneumonia is Streptococcus pneumoniae. This accounts for 36% of community-acquired pneumonia, up to 50% of our hospital-acquired pneumonia, and this can have a 5 to 7% fatality. So when we think about mortality, we think about that in terms of invasive pneumococcal disease, and really the majority are in our elderly population. However, this high-risk group, and remember, we only have 20% vaccination coverage for this high-risk group. So this high-risk group is also at an increased risk for invasive pneumococcal disease. This includes those with heart disease, diabetes, pulmonary, kidney, liver, alcohol. So if you have a diabetic, they're right there, 28% cases per 100,000 persons. That's a 3 to 7 times increased risk per year. And those with HIV, AIDS, cancer, that's a 20 times increased risk. So the good news is that we have 2 vaccines to help with this bacteria. One is the Pneumovax, that is the polysaccharide vaccine. That one's been around since 1983. And we think of that as being the adult standard. And then we have the conjugate vaccine. This is the Prevnar. And this is what we typically think is a pediatric standard vaccine. This has been around since the year 2000. So there's more than 90 different types of capsular of pneumococci. And these 23 serotypes were initially chosen because they cover about 85 to 90% of invasive pneumococcal disease. Now, this has now declined to cover about 60 to 70% of serotypes, and that's likely due to the indirect effects of the Prevnar. We know that immunity lasts at least 5 years following 1 dose, and the reduction in invasive pneumococcal disease, as far as efficacy, is about 60 to 70%. And there's really no reduction in decreasing pneumonia. Now, the indications is for all adults 65 and older. And again, for those younger in that high-risk group who have underlying heart disease, lung, liver, kidney disease, diabetes, smokers, alcoholics. I do want to make sure that sometimes I'm very careful not to call this the pneumonia shot when I'm talking to my patients, again, because it doesn't necessarily prevent pneumonia per se. And there's a lot of different bacteria, viruses, et cetera, that can cause pneumonia. But what it's going to do is it's going to prevent that infection if you were to get sick from getting into your bloodstream, getting into your spinal fluid, and that's when people die. So the problems with polysaccharide vaccines in general is that they are poorly immunogenic. So the highest risk populations fail to respond. These are infants or toddlers. And then for adults, the more older, frail, and more immunocompromised are also less likely to be protected with this vaccine. So that led to the development of the conjugate vaccine. When you conjugate the polysaccharide to a diphtheria-like protein, this greatly increases the immunogenicity of the vaccine. So with polysaccharide vaccines, you're really only stimulating the B cells and a dependent immune response, versus the conjugate vaccines stimulate the T cells, which then provide many advantages. They're immunogenic to the very young, and they also provide immune memory, booster effect, long-term protection, and herd immunity. And this is one of my favorite slides when I show the vaccine, because when the Prevnar was initially introduced with kids in the year 2000, you can see in that top slide, as soon as it was introduced, there was a 90% reduction in invasive pneumococcal disease in kids, 90%. And at the same time, with our adults, just by being an innocent bystander, there was a 45% decrease in invasive disease in adults with the introduction of the Prevnar. Now in 2010, they increased the Prevnar that had 7 valents to include the current vaccine today, which is the Prevnar 13. So this vaccine, these 13 serotypes, covers about a third of the invasive pneumococcal disease. The effectiveness in adults is that it's 75% effective against vaccine-type invasive pneumococcal disease. And it's 45% effective against vaccine-type pneumococcal pneumonia, which is about 10% of the cases. And it's because of this why the ACP rushed to recommend it in 2014 for our older adult population. So currently the recommendations for the Prevnar is you want to give it to those at highest risk for invasive pneumococcal disease before the age of 65. And then it's recommended since 2014 for all adults 65 and older. So this is certainly the most complicated of all the vaccines, so there are some ground rules when you're giving the vaccine. If both vaccines are recommended, you cannot be given them at the same time. Ideally, if they're naive, you want to give them the Prevnar first. People have a better response when they're given the Prevnar first over the Pneumovax. And you only need 1 dose of the Prevnar, and that's it. So whether a patient, if they're high risk and they got it, say, at age 30, versus if they're elderly, 65, they only get it once. And then once the patient's over the age of 65, they don't need any more boosters per the ACIP of the Pneumovax. And I think the best way to really talk about the schedule is to go through the algorithm, because again, this can get very confusing. So if you have a patient who has no other medical conditions, and they come in at 65, they'll get the Prevnar. 1 year later, and for those patients who are Medicare, this is really important because it is covered, but you have to wait more than 11 months. Then they get their Pneumovax, and then they're done. So if you go here, so now we have the patients who are at risk for invasive pneumococcal disease. They smoke, they live in a long-term care facility, or they have chronic medical conditions such as heart or lung disease, diabetes, alcoholism, chronic liver disease. They should get their Pneumovax. So let's say you have a diabetic who is 40 years old, you'd give them their Pneumovax then. Once they turn 65, they would get their Prevnar, and then 1 year later, at 66, they'd get the Pneumovax. So same patient, or let's say you have a patient who's 62, who's a diabetic, and then at 65, they get their Prevnar, and now at 67, they'd get their Pneumovax, and they're done. You have your higher risk category over here, so those patients who have a CSF leak or cochlear implant, again, they're at higher risk for invasive pneumococcal disease. They would need their Prevnar, and then 8 weeks later, they'd get their Pneumovax, and then once they're 65, they would get their last Pneumovax. And then you have your highest risk conditions, highest risk for invasive pneumococcal disease. They don't have a spleen, either functionally or anatomically, or they have immunocompromising conditions such as chronic renal failure, and that's a little vague, but essentially if you have a patient approaching dialysis or on dialysis, if they have nephrotic syndrome, if they have generalized malignancy, HIV infection, if you're anticipating immunocompromising them with immunosuppressive therapy, let's say you're going to start a TNF inhibitor. Those are all the highest risk conditions for invasive pneumococcal disease. They get their Prevnar. So let's say you have a patient with, who's on dialysis. You give them their Prevnar, say they're 40. Then you give them their Pneumovax 8 weeks later. 45, they get the Pneumovax. And then when they're 65, they get their Pneumovax. So that's it. So the take home for pneumococcal is that by the numbers, we have 2 vaccines, the Prevnar and the Pneumovax. We have 3 intervals to remember. There's 8 weeks between the Prevnar and the Pneumovax if given in the highest risk medical condition. There's 1 year between the Prevnar and the Pneumovax if the Pneumovax was given first. So I didn't really mention that in the algorithm. But if a patient had the Pneumovax, you have to wait an entire year before the Prevnar. Or if age is the only highest risk indication, and there's 5 years minimum between the doses of the Pneumovax. The maximum doses per the ACIP is 1 dose for the Prevnar and 3 for the Pneumovax if it was first given for the highest risk medical condition and the first was given before the age of 65. And as far as what's new, we're still waiting for some outcome data for the Prevnar. And the ACIP, they're going to evaluate this year and revise if needed. So the long-awaited shingles, I know this has been much anticipated, so I'm going to spend some time talking about this. Herpes zoster is reactivated varicella virus zoster. The lifetime risk of shingles is 1 in 3. There's about 1 million cases annually, and there's 50% risk of herpes zoster if a person lives to be 85 years old. Post-herpetic neuralgia is the most common complication of herpes zoster, and this risk increases with age. So there's about a 1 in 5 lifetime risk. And antiviral agents, they can decrease the resolution of lesions and severity of acute pain, but they do not reduce the risk of post-herpetic neuralgia. So very exciting. We now have 2 vaccines for this disease. With the Zostavax, and now we have the new Shingrix. So the Zostavax, this has been available for over a decade. This is a live attenuated varicella virus. It's pretty much the chickenpox vaccine times 14. Overall, this reduces shingles by 51%. It's about 64% effective in adults in their 60s, and it's only 38% effective when adults are 70 years and older. Now, despite this, the reduction in post-herpetic neuralgia is the same across all age groups, is about 66.5%. So the ACIP recommended a single dose to all immunocompetent adults ages 60 years and older. Again, this is a live attenuated vaccine, so you cannot use it if someone has AIDS with a CD4 count of less than 200, or if they're on immunocompromising medications, radiation therapy, etc. So this vaccine had a lot of problems. One, significantly, is the vaccine efficacy. It wanes over time, and it's found to only be 4% effective in the 8th year after vaccination. Also need a standalone freezer, so this could be problematic for some smaller practicing physicians who don't necessarily have a large storage for vaccines. Again, it's a live attenuated virus, so we are not including some of our adult population. And it's extremely expensive. You know, this vaccine, it's really, for our elderly population, most of them are Medicare. And unless they have Medicare Part D, which is the prescription drug plan, they're not going to be able to afford it. So there were 2 studies that came out that talked about the efficacy of the Shingrix, the new vaccine. So the first one on top, that was published in 2015, that's the Zoe 50, it had 15,400 patients. And the one on the bottom, which occurred at concurrently, the Zoe 70, that had about 13,900 patients, and it looked at the efficacy of this new vaccine in the 50 and older, and then specifically on the 70 and older population. The inclusion criteria included immunocompetent people who did not have a history of herpes zoster or have not received a prior herpes zoster vaccine. So this vaccine is a subunit vaccine containing a varicella zoster virus glycoprotein E and ASO1B adjuvant system. The recommendations for this vaccine will be 2 doses given at 0 and 2 months. And the ACIP recommended that we use it with our adults at the end of October. They unanimously recommended for the prevention of herpes zoster and related complications for immunocompetent adults ages 50 and older. So this is younger than the Zostavax recommendation. They say you can give it if they've received a previous Zostavax as long as you wait more than 8 weeks prior. And narrowly voted 8-7 that this is preferred over the Zostavax. So I'm anticipating that we're not going to see much Zostavax in the future. And the reason why is that this vaccine works great. So there's very high levels of protection. 97% effectiveness in shingles in adults from the 50s and in their 60s. 91% effectiveness against shingles in adults 70 years and older. And when they looked at post-herpetic neuralgia, that was 91% efficacious. And when they looked at the vaccine efficacy after about 4 years, it still maintained its effectiveness at 85%. Another way to think about this is the number needed to treat to prevent one zoster case is 13 people in their 50s, 11 people in their 60s. And I'm very excited about this vaccine, and when I'm telling my patients in clinic that it's going to be here any day, I also warn them that this vaccine works so well, it's going to rev up your immune system to help fight infection, but it's also going to give you a side effect. Very high incidence of reactogenicity, none serious reported, but a lot of people, almost 80%, had complaints about injection site reactions within the first 7 days. And of that, about 12% of the reactions were too severe to prevent normal activity. They found when they gave the second vaccine, this didn't change much, but this is very important to let your patients know ahead of time, you're going to get a side effect. Don't worry, it's going to go away, and you're going to get your second one to make sure this vaccine is going to work. So when you look at these two vaccines head-to-head, it's very difficult. I just wanted to summarize them, but it's difficult to do a direct comparison from different trials because they're different trials. For example, when they looked at the control group for post-herpetic neuralgia, there was actually a higher incidence in the Zostavax trial than there was in the control group for the Shingrix trial. So you have to wonder, was it a more frail population for Zostavax? Do they have a more sensitive case definition? Or were they just doing more active surveillance? But in general, if you're going to summarize, the Shingrix is more than 90% effective, and there's no decline with age, versus the Zostavax is only 51% effective, and there is a decline with age. There's 91% efficacy against post-herpetic neuralgia with Shingrix versus 66% efficacy against post-herpetic neuralgia. The Shingrix is not live, and the Zostavax is. The Shingrix does not need to be stored frozen, whereas the Zostavax does. And the Shingrix is going to be an intramuscular injection, while the Zostavax is a subcutaneous injection. So, summary for this, it's recommended over Zostavax starting at age 50. It's okay to give even the previous Zostavax vaccination. And we're still waiting for the availability. It's been told that early in the year, so maybe even this month. We're also waiting for recommendations for the immunocompromised. We can assume it's going to be okay since it's not a live vaccine. And then, of course, insurance coverage to see if it's going to be paid for. Right, moving on to the Tdap vaccine. So tetanus is the only vaccine that is not, or excuse me, the only disease that is not passed from person to person. It's in the environment, so we're never going to be able to eliminate tetanus. So we always have to give someone their tetanus vaccine. For diphtheria, a lot of diseases in the United States we've eliminated. Diphtheria being one of them, rubella, polio, but because international travel is so common, we still need to continue to vaccinate. Otherwise, we increase the risk of getting these diseases. And pertussis. So we peaked at pertussis in the 1930s, about 250,000 cases. And with the introduction of the vaccine, this has decreased to a nadir of about 1,000 cases in the 1970s. Unfortunately, over the last 10 years, we've been seeing a rise in pertussis cases. We really don't know why we've been seeing a resurgence of pertussis. It could be because of clinician awareness and more public health reporting. Perhaps we're just diagnosing it more because we have better tests. It could be because of vaccine waning induced immunity. We know it's effective about 75% of the time in the first year, and then it declines over the next 2 to 4 years. We perhaps aren't using the vaccine enough, or there's an increase, true increase in the bacteria or genetic changes in the strain of bacteria. So the recommendations per the ACIP is to give this vaccine to all adults 19 years and older, regardless of their last interval from their tetanus. And to give an example, let's say you have a patient who went to the ER after having an injury, and then you see them the next day for follow-up, and they got the TD. And you notice they've never had their Tdap before, you can actually give it to them the next day. Now, in our clinic, we have the Boostrix, but it doesn't really matter which one you have, because per the ACIP, even though the Boostrix is the one that's FDA approved for 65 and older, they're both immunogenic, so you can use whichever one you have available. An off-label recommendation per the ACIP is to give the Tdap in every pregnancy in the 3rd trimester. That's 27 to 36 weeks. And this is going to prevent pertussis in the mom, and it's going to protect the infant. Infants is the highest mortality with pertussis, so it's extremely important in order to cocoon and to help that infant. And we find that the vaccination is 93% effective in protecting against pertussis in infants less than 2 months old. Now, boards loves tetanus. Not only is it good to know, but for any of you who need to recertify or taking your boards, for acute wounds, it's good to give the tetanus vaccine if the last one was 5 years more. And if it's a clean wound, you can wait 10 years. And if they don't know if they've received the Tdap before, you can give them the Tdap instead of the tetanus. If you have a patient where they don't know if they've received the tetanus series at all, let's say they've moved from Mexico and they're establishing in your clinic, you can give them the 3-shot series at 0, 1, and 6 months, and only one of those need to be the Tdap. And for now, we still run a booster every 10 years with the TD throughout adulthood. So in summary, we want to give this vaccine to every adult ages 19 and older. We want to give it in every pregnancy. So if you have a woman who's getting pregnant every year, she's going to get the Tdap every year. And we need more data to see if it's going to be the Tdap every 10 years that's going to replace the TD. And finally, I'm going to talk about the hepatitis viruses or vaccine. This should be a familiar vaccine. This one has been around since the 1980s, so I think people in the room should be well versed with it. But the one indication that people always tend to forget is the recommendation for diabetics. So this is a grade A recommendation for diabetics from the ages of 19 through 59 to give this vaccine. And what the update was from the ACIP last year is they defined chronic liver disease. So this is for someone who has hepatitis C, cirrhosis, fatty liver, alcoholic liver disease, autoimmune hepatitis, or transaminases 2 times above the upper limit of normal. We also know that travel is an important reason to give the hepatitis B vaccination. There are high rates of hepatitis B in parts of sub-Saharan Africa, Western Africa, South Sudan. And there's relatively low rates in the United States, Canada, and Mexico. But most of the world, there's intermediate to high, so that's something that we do want to vaccinate for. The schedule has not changed. Again, when they come out with the approval, not the approval, but when the ACIP looks at the 2-dose hepatitis B, this may change. But for now, we're just giving 3 doses at 0, 1, and 6 months. Now, remember, these are minimum intervals. They're not maximum. So if you have a patient, let's say they miss their 1 month and you see them a year later, you don't have to start the series over. You can just continue with the vaccinations. And that vaccine is actually really good for otherwise healthy people, about 95%. Now, I added this in here because I know a lot of people wonder, well, why is the diabetic recommendation only up to age 59? And it's really just a cost effectiveness. So the seroconversion for diabetics from 40 to 59 is 80 to 90%, but the older they are, the less likely they are to mount a good immune response. That being said, if you have an older adult who, say, lives in assisted living and they're getting their finger pricked a lot, you may want to vaccinate them versus an older adult who's just on metformin and doesn't really check their sugars at home. So it's just something to consider. If you are going to test for post-vaccination antibody testing and these high-risk groups, you want to do it 1 to 2 months after the 3rd dose, and protection lasts at least 22 years. So the take-home for hepatitis B, remember this vaccine protects against cancer. There's 3 shots, but the intervals are minimums. And if you're going to monitor titers, do it 1 to 2 months after the last dose. And think about this for your diabetics. And also just remember there are updated chronic liver disease conditions if you have any questions about that group. And finally, I'm going to briefly talk about some travel during training for astronauts. And I do want to thank Dr. Ronak Shah for helping me with some of these groups, as well as Dr. Serena Anand, if she's listening from Russia right now. But these are the countries that I was given as far as they're frequently traveled for astronauts in training. Now, Russia and Kazakhstan, those are the ones that are developing countries, with Japan, Germany, and Canada being more industrialized. And you can see, actually, the vaccines are pretty similar. I got this information off the Travex website, which is what our infectious disease doctors at UTMB use when they're doing the travel clinic. So in general, all these countries, it's recommended to get the hepatitis A vaccine, influenza vaccine, the hepatitis B vaccine, and the MMR is recommended, again, because we're seeing these diseases in other countries. So if someone does not have evidence of immunity, if they're born after 1957, you do want to give them their 2 doses of their MMR. Now, Tdap, pneumococcal, and varicella, those are starred because they're not travel recommendations that are necessarily recommended, but they are just routine vaccinations that are recommended. Usually for these countries with pneumococcal, it would be if they have chronic medical conditions or if they're age. But my understanding with your astronaut corps is that you're giving them to this to the younger group regardless. And then varicella would also be if they don't have evidence of immunity. Now, Kazakhstan, you can see, is the only one that has an additional with typhoid. That is given intramuscular ×1, and you do it every 2 years. If you decide to give the oral typhoid, that is live attenuated, it's every other day for 4 days, and it's good for 5 years. But it's very important with this vaccine, do you remember it has to be refrigerated. So if someone just sticks it in their purse, it's not going to be good. And there's also some Things that you have to remember if you take it, you want to do it an hour before a meal. Make sure you take it with a cold or lukewarm drink. Now, I purposely do not have for Japan the Japanese encephalitis vaccine. And the reason why, even though that's highly prevalent in that country, that's only recommended for people who go to rural areas or if they're going to be there for prolonged stays. So that's not one that's not necessarily for your astronauts. However, it's not going to hurt them if they want to have that protection. So I just gave you all a ton of information. And this is an outstanding app if you're looking for something on your phone where you don't have to go to the CDC website. So if you download this the CDC vaccine schedule, it's free. And it basically gives you that chart that I showed in the beginning, and then you can click on it and it'll even tell you the footnotes. Also, www.immunize.org is a wonderful resource. I often go to it whenever I have vaccine questions or if I want to give some handouts for my patients. And of course, if you guys have any questions at all, please feel free to email me. If I don't know it, I will look it up and I will let you know. And thank you for your attention. I'll take any questions.
Thank you, Dr. Berman. That was excellent. Appreciate it. I'd like to open up the session for some questions, but stand by in the room here just for a moment. I'd like to first offer some questions from our offsite facilities. Does anyone have any questions? Okay, then I'm going to go ahead and open up to our room here. Go ahead. You're closest. I'm going to give it to you, Richard.
Couple of questions. If someone who's has already had shingles, is there any place for the shingles vaccine? And the second one, are there any data at all about using HPV in someone who's, say, 50 and has had a monogamous relationship and never had HPV, but now they're going to go back out and get exposed? Any data on is it effective in that group?
Thank you for those questions. So to answer your shingles vaccine first, yes, if someone's had a history of shingles, they should still get their vaccination. Now, if someone had shingles, their own immune system is going to produce an immune response, some antibodies, so you can safely wait about a year before giving them their vaccination. But if they had it once, they can get it again. For HPV, that really has not been studied in the population above the age of 26. So it would not be harmful if someone wanted to get their HPV series. It would not be covered by insurance. But again, that would be something, it would be an off-label use. And if someone is concerned about their risk, then they certainly can get vaccinated. The vaccine works best in those who are HPV naive. And typically that are the people who've never had any sexual activity, which is why we're trying to target the younger age group. Unfortunately, when HPV came out, we did a terrible job of marketing it, and that's why a lot of parents don't want to give their vaccine to the kids because it's a sexually transmitted, virus. But we really need to sell this as a cancer protection virus. And I'll tell you nowadays, and hopefully the pediatricians are doing this more, when kids go in for their checkup at age 11 and 12, the conversation is, great, today your child, we recommend that they get their 3 vaccines, their meningococcal vaccine, their HPV vaccine to prevent cancer, and their Tdap. Do you have any questions? Like that should be the vaccine or the conversation, not like, oh, well, do you want this one? Or, well, I only want what the school has. So hopefully we can encourage that. And again, I don't know if you all see adolescents, but maybe you can encourage your friends like, this is a vaccine that prevents cancer. I'm sorry, I don't have information though about the older folks, but that is something that I know more and more people are interested in. And again, it won't hurt someone if they got that vaccine.
Every now and then you hear about the universal one-shot for all-time flu vaccine. Is that urban legend, or is there actually any progress toward that?
So, thank you. There is a need for this universal flu vaccine, and I can promise you that they are working on it. I, of course, don't know anything about it, but I do know, just looking at all of the problems we are having with vaccine efficacy, especially with H3N2 and the decreased effectiveness, they are looking for a universal vaccine. So that is something that they are strongly working on. One day.
Great talk, thanks. I work in the Victory Lakes urgent care quite a bit, and we've just been swamped with flu patients like crazy. And I have patients that have that test negative, although you look at them and you'd swear they had the flu. And then there's patients that have both, that are both A and B positive. So I'm wondering if you could talk a little bit about the accuracy of that test, the
Yes.
rapid test.
Yes.
And then the second question, are there any populations, we hear about Tamiflu not being that effective or useful in the treatment of flu, just maybe it shortens your symptoms a little bit. Are there any populations that you strongly recommend use of Tamiflu for?
Yes, thank you. So those point of care tests only have a sensitivity of 50%. So if you really have a strong suspicion of influenza and when you're working in that setting, if you can send it for a PCR, that would be helpful because also you get the RSV. But if you have a high suspicion, you treat. So just what you're doing. As far as who to give Tamiflu to, really anyone within the first 48 hours, if they want to decrease the course of illness, certainly those with medical conditions, heart disease, or any medical problem for that matter. I can tell you, I personally had influenza a couple of years ago. I didn't treat myself, but I prophylaxed my kids. So they had to suffer through that. But it's because I knew I was otherwise healthy and I was going to be fine. So it really depends. It's an expensive antiviral treatment, but if used, especially within the first 48 hours, it is effective in reducing symptoms.
Do we have any more questions from the room? Well, great. Well, we'll go ahead and conclude our session here. Thanks again, Dr. Berman. We really appreciate the presentation.
Thank you all for being here.
We'll see you next time.